Hi everyone! Welcome to the 2020 Annual Net Cancer Day Symposium. Thank you for joining us live and honoring Net Cancer Day together. I'm Lindsay, the Director of Communications, and this is...
I'm Lisa, I'm the Program Director.
Before we get started, we'd like to extend a special thank you to Rich at TVP Live for making this virtual event and production possible. You rock, Rich! Here are a few tech reminders for today's virtual symposium. For your audio, be sure the volume on your computer is turned up, and double check that the volume is unmuted on the webinar broadcast screen. Also, for the video, you can enlarge the webinar broadcast screen by clicking the Expand Screen button in the bottom right corner. And also, just as a reminder, the full webinar video will be posted on the LACNETS YouTube channel within the next few days. We would like to thank our sponsors today, specifically our gold sponsors AAA, Sun Pharma, and Ipsen, as well as our silver sponsor, Tercera Pharmaceuticals. Patient advocacy groups are an important source of net news and resources, so we encourage you to sign up for our newsletter on our website and follow us on social media. You can find us on Facebook, Instagram, Twitter, and as I mentioned earlier, YouTube. A little disclaimer, these live LACNETS webinars are done for educational purposes only and not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. If you have a question or multiple questions for today's NET experts, please go to www.slido.com and enter event code NETCancerDay. The NET experts will be doing a live Q&A following their presentations. Now I'm going to pass it off to Lisa to talk about LACNETS and introduce today's speakers. Take it away, Lisa.
Thank you, Lindsay. LACNETS stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society, and our mission is to provide education, advocacy, and support for all people impacted by this rare disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer since we know that it is in fact a type of cancer. While you often see Lindsay and I leading the meetings and programs, we are led by a team which includes our interim administrator and board member, Kotiah Velikabuti, and board member Donna Gavin, also the sister of LACNETS founder and executive director emeritus, Giovanna Joyce Mbesi. We're pleased to announce our newest board member, Mary Dunleavy, who some of you may know from our regular meetings. You may remember hearing her talk about scanxiety at our June 2020 LACNETS annual conference. Not only does Mary bring a background in medical and sales training, she also brings the patient perspective, deep empathy, and a passion for helping others. In addition to our board members, we are grateful for the counsel of our advisory board. As you may already know, LACNETS was founded in 2012 by jazz musician and composer Giovanna Joyce Mbesi, who was a NET patient herself. Giovanna was diagnosed in 2005 with metastatic small bowel neuroendocrine cancer. She then pursued her MBA for the sole intent and purpose of launching a NET patient advocacy group in Los Angeles. She lived fully with her diagnosis for 14 years until succumbing to her disease in November 2019, just over a year ago. On her last day on this side of heaven, Giovanna said to me, with great pride, that she felt her greatest legacy was founding and building LACNETS, now one of the largest NET patient advocacy groups in the country. Our NET hero left behind a legacy and a vision. Her vision was to empower NET patients and caregivers by providing a healing exchange of educational resources and emotional support so they may learn to live richly and fully. To this end, we have launched the Vision Initiative. We launched this to coincide with Net Cancer Day, not just because of the global initiative to spread awareness about NETs. It's also because Net Cancer Day was always special to Giovanna, because Giovanna's birthday is November 9th, the day before Net Cancer Day. So while we're remembering Giovanna with the 1-year anniversary of her passing, this is truly a celebration of life. Giovanna liked to say, aging is a privilege. This perspective and gratitude comes when you're affected by cancer. To the general public, many people may have heard of NETs only because of celebrities such as Steve Jobs and Aretha Franklin, who sadly passed away from the disease. Our hope is to change the narrative from associating this disease with famous people who passed away from the disease to a growing awareness of the more than 180,000 people living with the disease. And we want to support you as you learn to adapt to your new normal and help you live richly and fully despite living with the disease. So we invite you to contribute to Giovanna's vision and help continue her greatest legacy. Your gift will be matched 1-to-1 up to $50,000 if you contribute by December 31st, 2020. Large or small, every gift matters and is greatly appreciated. If you have benefited from our programs, please consider paying it forward. We invite you to share the word and spread the vision to your family, friends, and community. You hear us often say that LACNETS is a NET community. We are a collaborative community of those living with the disease, meaning patients, family and friends supporting NET patients, meaning caregivers, NET experts, sponsors, and many more. And whoever you are, whatever your relationship is to NETs, you are an important part of that community. We do this for you. You inspire us. You make this possible. And we aim to build and strengthen this community, knowing that when we come together, we are stronger together. Today is an opportunity to learn from NET experts across the country, as well as hear stories from NET patients and their families. We hope you will be encouraged, knowing that you are not alone. There are many patients, caregivers, and advocates who are living through this, who understand and support you. Also, there are many experts and advocates fighting on your behalf. There is, in fact, a lot of NET research going on to try to find better treatments so that you can continue to thrive for many, many years. Our first guest today is NET patient Lori. Lori was diagnosed with NETs just over a year ago. Whether you're recently diagnosed with NETs or you've been living with NETs for many years, we all go through that initial shock and challenging first year. You'll be inspired to hear Lori's experience and what helped her during her first year. Next, NET patient oncologist Dr. Sandy Kotiah from Mercy Medical Center in Baltimore, Maryland, will be giving a presentation on NETs 101, an overview of the terminology and concepts related to NETs. Here is a fun fact about Dr. Sandy Kotiah. She is fluent in both French and Creole. Let's welcome NET patient Lori, followed by Dr. Kotiah.
Hello everyone, my name is Lori and I would like to share a bit of my cancer journey with you. I was diagnosed with a stage 4 pancreatic NET on January 7th, 2019. That was the day that I received the phone call from my primary care physician's office stating that she'd like to see me that same day. I had been experiencing gastrointestinal issues for over a year, trying to pinpoint what the problem was, and was initially assured it was probably GERD. My age and health history didn't point to anything alarming or urgent in their eyes. Of course, now I understand why we are called zebras. When I was finally sent for an MRI, the mystery was solved. It clearly showed the pancreatic tumor and metastatic lesions on my liver. That first discussion with my primary care doctor was a blur, and honestly not clear enough. I was sent off to schedule an appointment for a liver biopsy and to see an oncologist. The consultation with the oncologist did not provide much more confidence or clarity. I came away with the understanding that neuroendocrine tumors were somehow different than regular cancerous tumors and that I should begin octreotide injections, but not much more than that. I felt as though I was walking through a fog those first few weeks. I was searching desperately for light while everything around me felt very dark and information so obscure. Even the hospital rooms where I had my biopsy and the oncology offices with their dark lighting and non-responsive receptionists, and even nurses with varying levels of confidence and competence, was all very unsettling. I knew there had to be a better environment within which to embark on this journey ahead of me, and before going any further, I knew I wanted a second opinion. I didn't have a concept of a NET specialist at the time and scheduled an appointment with a doctor at another hospital whose name had come up more than once in recommendations. The experience at this new health provider was entirely different right from the start. The warm greeting by the receptionist, the calm lighting and artwork in the waiting room, the efficiency and demeanor of each person on the team before and after meeting with the physician himself was such a relief. The time he took in explaining all the details of my case and the options before me not only instilled confidence in him, but gave me a sense of my power back. I finally had some clarity, and equally important, someone who was listening to me. I was fortunate to be able to make health provider changes quickly and place my care in the hands of this new doctor and his team. My fiance Thomas and I left the office that day feeling more hopeful and more in control than we had in the past 3 weeks. There were more biopsies and scans ahead, but I did begin somatostatin analog treatment, and it would be another 2 months before I started oral chemotherapy. It was a rough start, and I felt like my life was lived between doctor's visits and whatever energy I could muster for work. But I felt supported and well cared for every step of the way, from the close circle I shared my diagnosis with, as well as my healthcare team. Still, I knew I had to be my own advocate in my healing, so I did my best to educate myself. I wanted to learn all I could about my particular cancer and began trying to sort through all the research on surviving cancer to find the most current and substantiated information that would be pertinent to me. It was all a bit overwhelming. So much seemed to not pertain to my circumstances or was simply confusing and contradictory. I wondered about the credibility of sources and at times found myself down a rabbit hole. A couple of months into chemo, I connected with the resource center a team member had told us about on our first visit, and through a nutritionist there, I learned about LACNETS. On my initial visit to the website, I wanted to jump for joy. Here was all the information on my specific condition that I'd been trying to piece together, and from knowledgeable, credible sources. It would be several more months before I would attend an event, but when I did, it was such an impactful experience to be in a room with other people and caregivers living with NETs. The information shared was so clear and relevant to my circumstances. I was grateful to have found such an invaluable resource and to start making connections with this community. After an entire year on the chemo, my tumors had shrunk significantly, and my doctor and I decided it was an appropriate time to stop and give my body a break. I've been off for almost 6 months now. I feel much more like myself, and I do my best to make the most of each day while I feel so strong. When I was diagnosed last year, in those foggy early days, I asked my cancer, "What are you here to teach me?" These are a few of my takeaways. First, you must be your own advocate. I realize not everyone has the privilege of choosing from many healthcare provider options, but you must speak up, ask questions, and push for responsiveness from whomever is providing your care. Second, seek out and accept support. It can come from so many places. We often just have to be willing to ask for help or simply let others love and support us. Third, seek things that bring you joy and laughter. In dark times, it's important to keep your spirit high, and through these dark times, Thomas and I have intentionally sought out material that brings us smiles, and he has done an amazing job of keeping me laughing. It is a great antidote to stress, and this year has been particularly stressful for all of us. Finally, remember to move, and to whatever extent possible, remember to rest. Both have been so important for me for balance and healing as I've coped with all the changes this past year. I was determined from the start of this journey to find the gift in the experience. It has made me more present to my daily life, to those I love, to the purpose of my work and what I'd like to contribute to this earth. My sense of gratitude has grown exponentially, and my appreciation for life is palpable. I find so much joy each day in small moments. It's made the hard days bearable and the good days that much sweeter. Last year was the hardest year of my life, but it was also one of the most beautiful. The love and support I received, the strength I found within myself while at my weakest physically, the new relationship I had to forge with my body, the clarity of priorities and purpose, the joy and gratitude in life in the midst of fear and uncertainty. It has all taught me so much about myself and given me so much. I know I am just at the very beginning of my journey, and that there are going to be many more treatments and ups and downs ahead. We are, as Thomas continually reminds me, adjusting to our new normal. We remember that, as Viktor Frankl noted, those who have a why to live can bear almost any how. We focus each day on our why. So I thank those of you who are much further along on this journey of living with NETs. You inspire me. And for those who are newly diagnosed, I wish you strength and courage as you find your own meaning in your journey. Thank you.
Hi, everybody. My name is Dr. Sandy Kotiah. I'm a medical oncologist at Mercy Medical Center in Baltimore, and I've been the director of the neuroendocrine program there for about 10 years. And today I was asked to give you guys a talk on NETs 101. I wanted to just jump right into it. When I came up with the slides for this talk, I was really thinking about my first visit with my patients and what I really want them to know about neuroendocrine tumors so that they can get as much out of that first visit as possible. So I decided to start by defining neuroendocrine tumors. To make it simple, these are tumors that are very rare. Most patients, when they have cancer of the internal lining of their organs, they develop a cancer called adenocarcinoma. So neuroendocrine tumors are not typically what we find when we biopsy the pancreas, the lung, the small bowel. But generally speaking, it tends to be better to find a neuroendocrine tumor when somebody is diagnosed. So they come from hormone-producing cells, and hormone-producing cells can be scattered in your organs, like your small bowel, and your lung, or they can be heaped up in hormone-producing glands, like your pancreas or your thyroid or your adrenal glands, which sit on top of your kidneys. So normally these cells function to make hormones, and the hormones are supposed to keep your body in balance. For example, if you think about the pancreas and you're eating a meal and you're making insulin and you're trying to store the sugar from the meal, then eventually when you stop eating, you have to stop making insulin, because if you don't, then your blood sugar is going to drop. And then if your blood sugar drops, you're going to be in trouble. So then your pancreas starts to make glucagon, so you can use your sugar reserves so that you can have energy to exercise. So that's what hormones usually do, keep everything in balance. So nobody really knows why patients develop neuroendocrine tumors that are slower growing especially. We just know that over the last several years, there's been a lot more cases of neuroendocrine tumor, partly because we have better technology, partly because we think that there's something driving up the growth of, driving the incidence of neuroendocrine tumors. So when I see somebody with a pancreatic neuroendocrine tumor, I tend to think about different types of hormones that they could produce, but most of them are non-functional. But I kind of separate that in my mind from other neuroendocrine tumors, just because the treatment can be a little bit different for pancreatic neuroendocrine tumors. But under the microscope, they all look the same, okay? So there's many different ways of classifying neuroendocrine tumors, and I'm gonna go over that with all of you today. So there's lots of terminology, there's lots of confusing words. I think that there's still a lot of this name carcinoid, or this term carcinoid being thrown around, and it can confuse a lot of people, including physicians. So I thought I would spend some time talking to you guys about neuroendocrine terms. So generally speaking, carcinoid tumors are tumors that are slow growing, neuroendocrine tumors that are slow growing. And they usually start in the small bowel. You can have them in the appendix and the lung, and in the stomach. So it can be in different areas, but they're slower growing neuroendocrine tumors. Neuroendocrine tumors, NET, is another term for tumors from hormone-producing cells that could potentially spread to other organs, but they don't necessarily need to do that, but they can. They have that potential. Neuroendocrine cancers or carcinomas refer to more aggressive neuroendocrine tumors, the ones that are faster growing, and they usually spread to other organs, and they usually can require chemotherapy to get under control. Then neuroendocrine neoplasms is just a term to capture both neuroendocrine tumors and neuroendocrine cancers or carcinomas. What's important for you guys to know? So when you're going to your first visit and you've just been diagnosed with a neuroendocrine tumor, your pathology report is very important because it will tell us a lot of information about, is your tumor growing quickly? Is your tumor growing slowly? So I ask the patients to sit down and we write everything down. Is your tumor well differentiated or poorly differentiated? Well differentiated tumors usually mean that they look more like normal hormone-producing cells. Poorly differentiated tumors usually mean that they're very disorganized, and if you took the cancer and you moved it to a different place, the pathologist would not be able to tell exactly where it started. So well-differentiated usually does better. Poorly differentiated usually does a little bit worse. They usually grow faster. So, and if your tumor is well-differentiated, what is the growth rate of the tumor? So for that, we look at things like Ki-67 and mitotic rate, which I'm going to go over in a little bit more detail later. And then the other question I ask is your tumor producing hormones? Because cells that look more like what they originated from still can retain the ability to do what they were meant to do originally. And so, so we ask about, symptoms related to hormone production, which I'll talk to you guys about a little bit later also. The location of your primary tumor matters because we do have some different options for cancers of different origins. And then the stage of your tumor tells us what kind of treatments you need. So is surgery going to be important in your care? Is medication going to be important in your care? Is radiation going to be important in your care? So all of these things are important. So we do something called T, N, and M staging, and we do that for all cancers, not just neuroendocrine tumors. And what we're looking at is, either the size or the depth of involvement in the organ it started in. Are your lymph nodes involved? And you have 600 lymph nodes. They're all over the place. They help you fight infection. So they can drain cancer from the area where it started to, the area where it spreads to. And what's deceptive about neuroendocrine tumors is sometimes you can't always see the primary tumor. It's so small that it can't be easily detected on scans. And sometimes when they've done, especially in the small bowel surgeries, they found multiple tumors sitting next to each other and very, very small tumors, as opposed to the, adenocarcinomas where you have a big mass where the cancer started and it spreads in a smaller mass to like other areas like the liver or the lymph nodes. So the stage of your tumor determines, what your treatment option is going to be. And we base that on your pathology and your imaging, or if you've had surgery, we base it off your surgery. So just remember that clinical staging of your tumor is not as accurate as pathologic staging. So, we can guess the sizes of things on scans, but usually when the surgeons take things out, if you're able to have surgery, then we know exactly how many lymph nodes are involved and what the size of your tumor is. And then we call that pathologic staging. So, so pathology, we talked about this a little bit in the prior slide. So differentiation is how it looks under the microscope, and the pathologist tells you that. So Ki-67 is a stain that they do, and they try to see how many cells are taking up that stain at the time of your surgery or your biopsy. And they come up with a percentage. And so that percentage tells us how many cells are trying to divide at the time of the biopsy. So we'll go over what the numbers mean in a second. Mitotic rate is how many cells are dividing under the microscope at the time of the surgery. So it gives you sort of similar information, but two different ways of looking at the same type of information. And we usually do both here at Mercy, but you don't necessarily have to do both, but whichever one is the higher one is the one that we go with. Okay, so here's what the grading of the tumor. So there's differentiation and grade, right? So grade tells you a little bit more about how fast it's going to grow. Differentiation tells you in the long run how you expect it to behave. So a well-differentiated tumor, it has a Ki-67 of usually less than 3%. This is actually a little bit outdated. It should be less than 3%. And then the G2 tumors should be 3 to 20%, which are the sort of intermediate growth. And then the faster growing tumors have over 20% Ki-67, over 20 mitotic index. So the magical number for our cutoff is 20. But that being said, there's very different behavior for patients who have Ki-67 of 20 to 55% versus 55 to 100%. So even though we had this hard cutoff of 20, it doesn't necessarily mean that somebody with a Ki-67 of 25% is going to behave the same as somebody with a Ki-67 of 80%. So at the end of the day, you have to take all of this into account. Now, the WHO, the World Health Organization, added this third category for well-differentiated grade 3 neuroendocrine tumors, for mainly pancreatic neuroendocrine tumors. That's where we've seen this category of patients. And so those patients tend to behave in between the G1, G2 versus the G3. So they have a better prognosis in the poorly differentiated G3, but not as great of a prognosis as the well-differentiated G1 and G2. So, so we take that into consideration when we make treatment decisions and moving forward. Okay, so the next slide is about pathology pitfalls. And, one of the things that's fascinating about neuroendocrine tumors is they're very heterogeneous, meaning that you can see somebody one day and see another person the next day, and they have the same pathology report. They're both well-differentiated tumors, or they have a low growth rate, and then you don't know exactly how fast the tumor is going to grow until you follow them. So sometimes when you get a biopsy, you're not getting the entire tumor, you're only getting a representation of the tumor. That might represent the growth rate in all the areas where the tumor is, or there might be a different growth rate in a different part of the tumor. So we keep that in mind, and we tell patients, generally speaking, if you have a well-differentiated neuroendocrine tumor and the growth rate is low, then we expect your tumor to grow slowly, but slowly could mean different things for different people. Some people, it takes years for them to grow a half a centimeter, and other patients, it takes a year or two before they grow a half a centimeter. So we have to kind of take all of that into consideration when we look at the pathology. The other thing is that, that there's that unique category that I talked to you guys about, which is the well-differentiated high-grade tumors, where we're trying to do some studies to include those patients to try to see what the best treatment options are. Some people, they can get treatment the way that we treat slow-growing tumors. Some people will need treatment the way we treat fast-growing tumors. And it's not always easy to know which way to go until you look at the patient, look at their liver burden, and decide whether or not you're going to go with, hormonal manipulation, which we'll talk about later in the talk, or whether you're going to try to give them oral chemotherapy. So these are all things that we look at when we look at pathology reports. So it's good guidance, but it's not everything. So I just want you guys to remember that. Okay, so what about lab testing for neuroendocrine tumors? So I know that one of the things that probably drives me the most crazy is the fact that people get very caught up in numbers. And I realize that that's important because it's data, and everybody likes to follow data. So there's no great tumor for neuroendocrine. There's no great tumor marker for neuroendocrine tumors. In the ideal world, a tumor marker is a protein that gets released into your bloodstream, and it tells you exactly how your neuroendocrine tumor is doing. Is a neuroendocrine tumor growing? Then the tumor marker is going up in your blood. Is a neuroendocrine tumor going down? Then the tumor marker is going down in your blood. And then we don't have to rely so much on scans. But the reality is that even for other cancers where we have proteins that we can measure, there's no perfect test. And certainly for neuroendocrine tumors, the chromogranin A is a very imperfect test because it's not very sensitive or specific for neuroendocrine tumors only. It can be affected by decreased kidney clearance. It can be affected by liver dysfunction, which a lot of patients with neuroendocrine tumors can have just because they have cancer in their liver. It can be affected by acid reflux medication. It can be affected by inflammation in your stomach. So, the lab can fluctuate depending on what you're taking for medication and what's going on in your body at the time. And if you go to LabCorp, which is one of the labs we have here in Maryland, versus Quest, the different labs have different assays, so their ranges of normal are different. So, you try to keep things consistent, tell the patients to get it done in the same lab each time, and try as much to control things that you can control, like if they're taking acid reflux medication, I don't necessarily stop it. I just tell them we're going to follow the trend on your acid reflux medication. Because if it's trending steadily up over time, then you might be looking at somebody who's going to have growth in their scans at some point. Does that mean that the growth in the scan is going to happen, within the next 6 months? No, it could still be a while before they have growth on their scans. So, to me, I treat the scans. I don't treat the tumor marker. The tumor marker can give me some information. I might do a scan a little bit sooner than I plan if I see a fairly quick trend, but otherwise, which is not usually the case with neuroendocrine tumors, but otherwise, it's just data for me to collect. And if it was up to me, and I know that there's some neuroendocrine experts out there in the States that just don't draw chromogranin A because people get caught up in that that blood work, and it's not the most accurate thing we have. And I usually ask the patients to do fasting blood work. Now, when I'm talking about tumor markers for neuroendocrine tumors, I'm talking about the slow-growing ones. So chromogranin A is not something we draw for faster-growing neuroendocrine tumors that have growth rates over 55% especially. Okay, so what about other labs that we can do? So we tried to come up with a better tumor marker, and pancreastatin is a fraction of the chromogranin A. It's a portion of the chromogranin A. And the assay is available. It's been available for years, but not all of us are using it consistently. And what's more attractive about this tumor marker is that it's not as easily influenced by drugs or medical conditions that you have. So sometimes if somebody has a high chromogranin A and I'm not sure what's going on, I try to draw the pancreastatin to see whether that's elevated as well. And it's a test you can order through Quest, through some of the commercial labs. Pancreatic polypeptide is a protein that gets released into the bloodstream by some neuroendocrine tumors that come from the pancreas. So if you have somebody who has a pancreatic neuroendocrine tumor, and the tumor is not producing hormones, which is like 80% of them, you can potentially draw a pancreatic polypeptide. That being said, again, I don't base my treatment based on due to the pancreatic polypeptide. I can draw the test, but I feel like blood tests create more anxiety in general than they help patients because the tests are imperfect. It's always, to me, is there growth on your scans? Is there a change in your scans? Because that's what will drive us to change treatment. Also, the other thing that will drive us to change treatment is how are your symptoms? If you have a functional tumor, you're making hormones, is your hormone production controlled? Is your quality of life as maximized as possible? So again, we're still talking about slow-growing neuroendocrine tumors because there is no tumor marker for fast-growing neuroendocrine tumors that we usually generally follow. So again, for functional tumors, so people who make hormones, it depends where your cancer originated, what hormone you're going to make. So the most infamous example of hormone production is patients who have carcinoid syndrome. Carcinoid syndrome is when you're making too much serotonin, and serotonin is a hormone that usually makes a protein called niacin. But anyway, serotonin is a hormone that can cause flushing, dry flushing of your face, and it can cause diarrhea that's so bad that it wakes you up at night. And taking Imodium and Lamodal is not going to actually help those symptoms. So, we can measure the hormone production by looking at your 24-hour urine 5-HIA, which I will talk to you guys about in a second. And then, in terms of, do you change treatment plan? Well, it depends on the person's quality of life. But what we have to understand is, although we have very good drugs now to control hormone production, they're not drugs that necessarily resolve it completely. So most people will have improvement of their symptoms, but not complete resolution. And how much it bothers them will guide us towards whether or not we need to be more intensive or try to do more to control their symptoms. Okay, so serotonin production for me is best measured by 5-HIA, which is a breakdown product of serotonin that you can measure in the urine. You can do the 24-hour urine, which most people hate. Nobody wants to do the jug for 24 hours. Everybody complains about that, and I don't blame them. I wouldn't want to do it either. So if you're really not a fan, you can do the fasting plasma 5-HIA. And it's a test that requires you to fast for about 8 hours, and you can just come in and get your blood drawn. Now, there's a special tube. It's a Z-top tube. It has to be sent frozen. So the lab has to be taught how to process it correctly. Otherwise, you're going to keep running into a wall where you have to get it redrawn. It took us some years to train our lab to draw it. But it is something that's also commercially available. And most patients who have neuroendocrine tumors that have carcinoid syndrome, because they're making too much serotonin, they have liver spread. Okay, only about 9% of the patients only have their tumor still in their small bowel or their lymph nodes. Most of them, it's when their liver starts to make the serotonin that they start to get a lot of symptoms and get into trouble with diarrhea and flushing. There's other symptoms too, but those are the two major ones. In the pancreas, again, most of them are non-functional, but you can make too much insulin. You can have too much somatostatin. You can make too much glucagon. You can make too much VIP level, hormone level. VIP can cause a lot of diarrhea and low potassium. Insulin can really drop your sugar, and patients can faint from having low sugar. Glucagon can give you diabetes and blood clots. Gastrin can be high, can cause acid reflux symptoms. So sometimes you can tell just based on the way that the patients present whether or not they're having functional tumor, and you can try to see which level you want to draw based on what they're saying. Sometimes you just draw a few of them because you're not quite sure, but you're suspicious. Stomach neuroendocrine tumors, we usually look at gastrin levels. If your gastrin level is elevated, then that helps us figure out which type of neuroendocrine tumor of the stomach you have, because there's different types. There's type 1, type 2, type 3, and type 4, which is very different than the stage. The stage is how far spread it is. The type just tells us whether or not we need to be more or less aggressive with your treatment. So colon and rectal neuroendocrine tumors are usually non-functional. So if somebody has a rectal neuroendocrine tumor, the majority of the time there's no symptoms and they're not producing hormones. So what about imaging? So the biggest pet peeve I have with imaging is I want my patients to try to get apples to apples comparison, orange to orange comparisons. So it's very hard for the radiologists, from talking to them and reviewing scans with them, when I ask them, can you compare the gallium scan to the patient's CAT scan? No, that they're not going to do that, because it's hard for them, because they're different tests and they give you different bits of information. So CAT scans with contrast and MRI with contrast, usually we use EOVIST, are scans that measure things. How big is something, and how, like, they can measure in like 2 or 3 dimensions. MRIs are really great pictures of the liver. And sometimes we need great pictures of the liver because the surgeon wants to plan surgery, or the CAT scan is showing something, but it's not that clear, and we want to try to get a better idea what your liver burden is. So depending on which one works better for you, if the CAT scan is showing everything, you don't need to get an MRI, because most patients do not love getting MRIs because they can make you claustrophobic, you can be enclosed, but other people don't mind. But if the CAT scan is not showing things as well, then you get an MRI of the liver. So when I'm looking at, well, did your mass grow? And did it grow more than 20%? Because that's usually how we gauge change. Then I'm looking at the CAT scan and the MRI. And the pitfall that you don't want to fall into is that the person's only looking at the scan from 6 months ago. Because sometimes if you have somebody on treatment, like I've had patients on treatment for like 3-4 years with like Afinitor or everolimus, and the scan's always like stable, stable, stable. I will make the radiologist look at the scan from 2020 and look back at the scan from 2016 and really make sure that things are stable. So that's the sort of the caveats about scans that I try to think about when I'm going over imaging with patients. CAT scans and MRIs can be done for patients with fast-growing or slow-growing neuroendocrine tumors. But gallium scanning is really for patients who have slower-growing neuroendocrine tumors. So patients with Ki-67 or mitotic rates less than 20. Now, does that mean that you can't get a gallium scan on somebody who's well differentiated with a Ki-67 of 20 to 55%? No, you can certainly do that, because some of those patients will have positive gallium scans, and that might open up some treatment options for them. Now, the gallium-68 is one radio tracer that you tag to somatostatin, which is a hormone that controls the production of other hormones. And most hormone-producing cells have 1 or 2 receptors for somatostatin. Neuroendocrine tumors have over 50 receptors for somatostatin. So we use that to our advantage to treat neuroendocrine tumors and control the growth, because we've made long-acting somatostatin drugs. And we use it to try to give a treatment called PRRT, where we tag radiation to the somatostatin molecule and we inject it in the vein, and wherever there's overexpression of these receptors where these neuroendocrine tumors are, we can release radiation directly to the tumor. So there's tracers like indium-111, which was an old tracer that we used for Octria scans, but the Octria scans were not very specific or sensitive. Sometimes people would have negative Octria scans, but actually have the receptors there. So we came up with a much better tracer that was approved in 2016 called gallium-68, but human beings like to improve on things and perfect things, right? So this year we had approval of copper-64, and that even gives you even crisper images. And the limitation with the copper-64 is going to be that since it's a fairly new indication, fairly new approval, that the insurance companies are probably going to struggle to get this approved initially. So we have to push them and send them data and explain to them what this test is for, because believe it or not, when gallium-68 came out, I had to spend a lot of time sending appeals in just to get insurance companies to know what it was and what it did. And now it's like not a problem to get a gallium scan. So I think it's just a matter of educating the insurance companies, and then eventually they'll catch on. So, you know, you might see some of your physicians order a copper-64 in the future, which is fine. You know, it's just a matter of trying to find those receptors. And the other advantage of the copper-64 is that the drug tends to be stable longer. So if you miss your scan, it's not necessarily, we don't have to necessarily waste the drug if something happened. We can still hold that tracer and give you your scan maybe a week later or a couple weeks later. Now, I do tell patients who have carcinoid syndrome, right, which are the patients who are usually small bowel neuroendocrine tumors that have metastasized to the liver, sometimes appendix, about 10% of the time lung neuroendocrine tumors, that if you have had a high level of serotonin production for many, many years before somebody finally diagnosed you, which I think hopefully is becoming a thing of the past with Dr. Google, that you should get an ultrasound of your heart and make sure that the valves of your heart are fine. Because in the past, people used to have heart failure because they had uncontrolled serotonin that was causing scarring and damage to the right side of the heart. So we always get a baseline echocardiogram. And especially if your serotonin levels are 3 to 4 times higher than they should be, not serotonin levels, but the 24-hour urine 5-HIAA or the plasma 5-HIAA. So that's just something for you guys to remember. Okay, so this is a neat little cartoon. I can't take credit for it. I didn't really draw this, but I stole it from somebody. And what it shows you is what I was talking to you guys about. So here are these receptors on the surface of your neuroendocrine cell. And it's only 3 of them showing here, but just imagine there's 50 of them just clustering around the cell. And so here comes somatostatin. And you can give, lanreotide, octreotide, or like we call it cytostatin or somatulin, which are long-acting forms of somatostatin. Because somatostatin usually lasts about 1 to 2 minutes in your blood. But we made a form of it that can last 28 days and is a slow, steady release of the drug. So it binds to the receptor, and when somatostatin analogs bind to the receptor, they can stabilize these neuroendocrine tumors and prevent them from growing. So you can slow down an even slower growing neuroendocrine tumor. So again, somatostatin analogs are for slow growing neuroendocrine tumors, not for fast growing neuroendocrine tumors. So what they do is they attach this radiation emitter called Lutathera to the somatostatin. Then it comes to the tumor and it binds to the receptor, and then it gets internalized by the cancer cell, and then the radiation releases inside the cancer cell. So they'll have a different cartoon later on to show you how it works. And that's how Lutathera works, or PRRT, which is a way to give targeted radiation to neuroendocrine tumors that are slower growing. Okay, and then it's also how somatostatin analogs work, by using these receptors. And that's also how gallium scan works and copper 64 scans work. We're trying to find these receptors so it can light up wherever the neuroendocrine tumors are. Now, one of the things I did not mention to you is, do we use a gallium scan to follow for progression? And that's a very controversial thing, because we really use the gallium scan for, is that person going to respond to somatostatin analog, and is that person going to respond to PRRT? Now, if I get a gallium scan on somebody and a year later new spots are showing, new spots are lighting up, do I necessarily always worry about that? Well, it depends. Is their CAT scan or their MRI showing growth in that area? Because what happens with these types of scans is that sometimes it will light up before there's actually growth there. It might be very, very early. So we don't always want to change things unless we see growth, because growth is what drives us to change therapy and something actually showing up that we can measure. So I think for the most part, I've been using the gallium scan to help guide treatment, especially for PRRT. Sometimes I use it to try to, if I'm not sure if something popped up on a CAT scan or MRI, I'm not sure if that's a neuroendocrine tumor, I will add a gallium scan or a copper 64 scan to see whether or not that's showing activity. And if it's showing activity, then I'm like, okay, that's another neuroendocrine tumor. That's sort of how I use the scans. Okay, so now what about fast-growing neuroendocrine tumors? I know I've been discriminating against them. I've just been talking about slow-growing neuroendocrine tumors. I don't want to leave out the fast-growing neuroendocrine tumors. So again, like CAT scans of the chest, abdomen, and pelvis with contrast, absolutely. FDG PET scans, so what's the difference between gallium scans and FDG PET scans? FDG PET scans is basically looking at glucose, and you're tagging sugar, glucose, with a radio tracer, and you're injecting it in the vein. And wherever there's fast-growing cancers, generally speaking, which are neuroendocrine tumors, that have Ki-67 that is over 20%, over 55% for sure, it will light up on the PET scan. We usually get that. And wherever there's the areas light up, we can stage the patients and we can see where the disease is. Now, small cell cancer of the lung can spread to the brain. It has an 80% chance of spreading to the brain. So we usually get a baseline MRI of the brain. We follow after that. If it's negative, we follow after that for symptoms like headaches or dizziness to see whether we should get another one. But we do get a baseline MRI of the brain, with and without contrast. How do we decide how to treat neuroendocrine patients? So what I love about neuroendocrine tumors is not everybody who comes through the doors of my office will always get the same treatment. It has to be individualized. So every person is different. Patients can have different medical problems. They can have different liver burdens. They can have different symptoms. Some people can have bowel obstruction because they're having a small bowel neuroendocrine tumor that's, preventing them from eating. So depending on what's going on, we come up with different treatment plans for the patients. Do they usually see the same type of drugs? Usually. Do they see them in the same sequence? Not always the same sequence. It depends on the person and what's going on with them. So we would like to think as oncologists that we always give treatment based on clinical trials and data. We like to see survival data, but survival data is really hard to show for slow-growing neuroendocrine tumors, slow-growing tumors in general, because the patients live so long, you have to follow them for sometimes decades to show that there's a survival benefit. So our marker for showing that something is working is what we look at progression-free survival. If you can show that the patient's living a longer time with the cancer not bothering them, then we base our treatments off of that. So there's been an explosion of clinical trials, an explosion of treatments in the last 10 years. I have to say that I'm very proud of the neuroendocrine community in general. There's been a big push in the last 11 years. The North American Neuroendocrine Tumor Society formed 11 years ago, and there's been a huge amount of patient support groups like LACNETS that have arisen to support NANETS as well as the patients. And for that reason, even though we were lagging far behind the Europeans in terms of treatment, because when I started the program 11 years ago, there was only somatostatin analogs. And now, look at all the stuff that we have. We have a lot of stuff. You guys are going to be impressed. I'm going to go over that in a little bit. But we want to know that that we can tell the patients' response rates, we can tell the patients what they should expect side effects wise and what they should expect in terms of their quality of life when we're discussing treatment options with them, risk benefits, because the patients need to be involved in decision making. We give advice, we give options, and we'll give our opinion, but at the end of the day, the patients have to decide. So in general, slow-growing tumors that don't divide that fast are really hard to shrink. Right, because chemotherapy works great for fast-growing tumors because as it's trying to divide, it's damaging the DNA, and then the chemotherapy can kind of just put the cells to sleep. If it's an advanced cancer, sometimes it can improve the cure rate or the survival for people who have not had spread to other organs. Slow-growing tumors, we usually try to keep things stable. There are a couple of treatments that can potentially shrink the tumors down, which we'll talk about in a second. Okay, so these are for slow-growing tumors, okay? So somatostatin analogs we've discussed a few minutes ago. So that the two standard somatostatin analogs that we have are lanreotide and octreotide. There are more somatostatin analogs than that, but right now these are the two that are approved to be used for patients with neuroendocrine tumors that are slow-growing from the pancreas to small bowel. Is it approved for lung? No, but have we used it for lung? Yes, we've used it for lung neuroendocrine tumors and have had success. And that's based on just lots of years, decades of what we did in the past before there was any great treatment. So everolimus, Afinitor, and Sutent are pills that we can give, and the pills are supposed to block blood vessel growth of the tumor because neuroendocrine tumors have very rich blood supply. And if we can cut off the nutrients to the neuroendocrine tumors, we can stabilize the tumor. The stabilization rate of everolimus is about 80%. Okay, the shrinkage rate is about 1 to 2%. So it usually keeps things stable, doesn't usually shrink things, but this drug has been approved for all forms of slow-growing neuroendocrine tumor. Lung, pancreas, small bowel, appendix has been approved for all of them. The Sutent or sunitinib is a drug that's mainly been approved for pancreas neuroendocrine tumor. So now, are these drugs easy to take? Not always. So sometimes I have to reduce the doses because they can be quite toxic, almost as toxic as chemotherapy, but there are people who will do very well with them. Like I've said, I have some patients who've been on it for years, and it requires some dose modification, some aggressive management of symptoms, and some people are able to take it. So, that's in our armamentum. We can use these drugs, they're available, and they've been FDA approved. So what about liver-directed therapy? Liver-directed therapy is when you're trying to take advantage of the fact that these tumors have very rich blood supply and you're trying to cut off nutrition to the tumor. So you can do that in many ways. You can feed chemotherapy through the artery. We call that chemoembolization. You can feed radiation to the artery. We call that radioembolization. You can just cut off the blood supply with something bland, and we call that bland embolization. Don't actually give a chemical, just kind of reduce the blood flow to that part of the tumor. And the interventional radiologists are the ones who give that treatment. And we tend to think that it works better for small bowel neuroendocrine tumors than for pancreatic neuroendocrine tumors. But we have used it for both. And we're still trying to figure out what is the best treatment plan. Usually for radioembolization, we try to hold off giving that to patients with slow-growing neuroendocrine tumors because there's been some concerns that within a few years, patients can develop cirrhosis of their liver from damage to some normal tissue. So we only hold out for radioembolization when we think that somebody has a very aggressive tumor, faster growing tumor, and that they're not likely to see the complications from that treatment, but they're more likely to see the benefit. And of course, we have good old chemotherapy. Now, chemotherapy does not really work for appendix neuroendocrine tumor or GI neuroendocrine tumor because these cancers don't grow fast enough to be killed off by chemotherapy. However, Dr. Strasberg, who's a good friend of mine in Moffitt, has developed this Xeloda and Temodar or capecitabine Temodar regimen, which is 2 oral chemotherapy drugs that have worked fairly well for slow-growing pancreatic and lung neuroendocrine tumors. So it's not that we haven't used chemotherapy for slow-growing neuroendocrine tumors. It's just not our preferred choice first line unless it's a pancreatic patient. The pancreatic patients can have good shrinkage and what we call, cytoreduction is what we call kind of shrinking of the cancer. So sometimes we've done that first line for patients who have a higher liver burden to try to get some good control of the liver. So there are times when we'll use it. And of course, we've talked about PRRT. And, again, what I want to point out is, for patients who are in the in-between space where you have well-differentiated tumor, but your growth rate is between 20 to 55%, then it depends how your cancer is behaving over time with your imaging, whether we're going to go more for chemotherapy options or whether we're going to go more for PRRT, especially if you have a positive gallium scan or a copper-64 scan, or whether we're going to go for like Sutent or everolimus or one of the other somatostatin analogs. So these are things that we're still learning and things are evolving over time. And the liver burden is what drives a lot of my decision making. So when I see a patient for the first time, I say to them, okay, let me take a look at your liver. And most of the time, I don't necessarily have to worry about little ditzels that they find in the bones or little areas in the lung. I don't generally have to worry about them. That's been my experience the last 10 years. But the liver is an area where the cancer tends to thrive more. So I always look at it. I'm like, is 20% of your liver involved? Is 40% of your liver? Is 80% of your liver involved? Because that will tell me what I want to do in terms of the next step for that patient. And I always ask the surgeons for slow-growing neuroendocrine patients, do you want to do surgery on this patient? And not everybody's been on board with that. Some people think that surgery resets the clock, but most of the neuroendocrine surgeons in the U.S. will tell you that they can reset the clock for you and push back the need for drugs. So they want to at least take a look at your liver to decide whether they can debulk or try to remove at least 70% of your tumor burden. And if you have syndrome, then it can really help control your syndrome. So these are things that we talk about in a group. So we always meet and discuss things with all the different disciplines, with the surgeons, with the medical oncologists. The radiation oncologist plays some role, not that much of a role. We have nutritionists, we have social workers, because there's always some issue with diarrhea and bowels for some of the small bowel neuroendocrine patients. So all these patients, all these pieces are very important to try to get you the best mental health and the best physical health so that you can keep going and have the best quality of life. So this is another cartoon because I'm in love with the technology for PRRT. Looking at this radiation emitter called Lutathera that's binding to the somatostatin hormone, and then that's binding to the receptor, and then it gets into your cell, and the radiation travels 1 to 2 millimeters, and it can destroy these cancer cells. Now, the thing that is sort of disappointing in a way is not everybody responds to PRRT. The response rates are about 20%, and we're trying to look at other agents, other radiation agents that we can add to make this more effective or to increase the response. But some of the patients who respond to PRRT have responded for years and have done very well, and patients have been able to stay off of drugs. So it's certainly something worth doing, especially in slow-growing neuroendocrine tumors, and it's generally very well tolerated. And it's an infusion that's about every 2 months, and you get 4 treatments. And the biggest risk used to be nausea, immediate risk, used to be nausea from an amino acid infusion that we gave to prevent kidney failure, but the formulation has changed, and patients actually do very well now in terms of nausea and vomiting. And there's some small risk of kidney failure and bone marrow toxicity, especially with platelets dropping, which we watch for during treatment, but generally speaking, it's a well-tolerated treatment. Okay, so what about fast-growing cancers? Fast-growing cancers can be tough. I think that chemotherapy tends to work very well. The response rates are usually about 60 to 80% of people respond to chemotherapy, but it can relapse within a few months. Some people 6 months, some people 9 months, some people 12 months. There's a 5% cure rate with chemotherapy with small cell cancer of the lung, even if it's spread. So there's always going to be a small amount of patients who can get a cure from chemotherapy. But generally speaking, patients see their cancer come back. So, you can give platinum etoposide, cisplatin, carboplatin, or the drugs with etoposide. Sometimes you can give zolbetuximab. We've used another chemo regimen called FOLFIRINOX. I've done that a lot in conjunction with Dr. Strasberg, that I've seen some responses. And then the thing that's sort of relatively new, I think, within the last year or so for small cell lung cancer is immunotherapy. So immunotherapy is a treatment where you get your own white blood cells, your lymphocytes, which are your white cells that help you kill viruses and bacteria, to fight your cancer cells and wake up and kill them off. And immunotherapy in general has done very well across the board for lots of cancers. And I've seen some patients have complete responses where the cancer completely disappears, even with stage 4 disease, with immunotherapy, but it doesn't work for everyone. So that's a disappointing thing. But it's something that we want to try to add, and it adds some months of survival for small cell lung cancer. Some people have done better than that, but on average, it adds some months to your survival. So usually I tell the patients to look into getting chemo and immunotherapy for faster growing neuroendocrine tumors. So this is the final slide. So what I want to convey to you is your pathology report is important, your stage is important, your imaging is important, and the understanding of how your treatment works is important to me. Because if you know how your treatment works and you know what side effects to expect, then it makes sense that you're going to be able to communicate with me if something's not working well, and we're going to be able to talk about how things are going over the course of time. We want all our patients to do well. I always want everybody to have the best quality of life, because to me that's the most important thing. You don't always get to choose things that happen to you in life. You don't get to choose a lot of what happens to you in life. But if you're going to have cancer and it's going to be something that you can't cure but you have to live with, then the best thing to do is to live your life to the fullest and keep your symptoms under control as much as we can help you to do that. And, try to make sure that you don't get too caught up in labs and blood work and data points, because that will create stress and drive down your quality of life. I use laboratory studies mainly to guide my symptom management. So if somebody's telling me they have diarrhea and they're a patient who has carcinoid syndrome, and I'm not sure if the diarrhea is coming from the sandostatin or the somatrogon that I'm giving them versus carcinoid syndrome versus pancreatic insufficiency, because sometimes the somatostatin analogs can cause the pancreas not to make enough digestive enzyme. I draw the 5-HIAA. If the 5-HIAA is down and the patient's having diarrhea, then I look at the fecal fat. Is there fat in their stool? If there's fat in their stool and they're having pancreatic insufficiency, I give them Creon. If it's the lanreotide or octreotide, then it's better for me to know that, because I can always give them some Imodium or something else. So laboratories can be helpful for symptom management. I don't think they're as helpful always to tell us what's going on with the cancers. And some other people might disagree with me, but at the end of the day, sometimes when you draw a tumor marker and you see it going up, but nothing's going on the scans, sometimes you generate a lot of anxiety for people because they're anticipating the worst. And they might go a while before their imaging shows something. And so you really want to try to, the laboratory studies are going to see that your chromogranin A is elevating, and I'm going to do something about it, then that's fine. Then I'm happy to draw your chromogranin A every month or every week. But if it's just something that's a data point for me and I'm really looking at your scans to see whether there's growth, then I put that in some perspective. Like, do I really want to go chasing the chromogranin A? And I've chased many chromogranin A because people have been anxious, and most of the time it ends up being just bouncing around, fluctuating, and not doing anything. And if you get imaging, remember that you should try to get the same imaging for comparison. So if you're getting a CAT scan to follow your cancer, you should keep getting CAT scans. If you decide to switch to an MRI, then the MRI should be the way you go forward, so that you can compare apples to apples and oranges to oranges. So I'm hoping that over time we continue to have more treatment for the fast-growing patients, for the slow-growing patients. We're certainly doing a lot of research. There's a lot more awareness. And I'm very, very hopeful for the patients, and I'm very pleased with the way things have been going and the fact that I can give people so many more treatment options. So always keep some hope in your heart and try to stay positive and make sure that your quality of life is maximized as much as possible. That's my last takeaway point. And on that note, I'm going to stop.